is the last part of the lecture, and we'll be talking about the movement disorders and the auriculotemporal syndrome. And the movement disorders, this includes two disorders, the orofacial dyskinesia and oromandibular dystonia. The orofacial dyskinesia or tardive dyskinesia is involuntary, repetitive, soft text or movement of the mouth and face, while dystonia, it is also involuntary, but there is excessive muscle contraction that causes this condition, and usually it is associated with pain and discomfort. So let's see the difference. This is an example of orofacial dyskinesia, and as you can see, here the patient is moving her lips, and this movement is soft movement. There is no twitching, there is no muscle contraction. It is just this soft movement of the face, usually the lips, and the patient cannot control it. What causes this problem? The most common cause is medication, neuroleptic medications, antipsychotic medications. They induce tardive dyskinesia. So if the condition is related to taking medication, antipsychotic medication, we call it tardive dyskinesia. While orofacial dyskinesia are caused by any other cause other than medication. This includes advancing age. So sometimes some patients as they get older, and you can probably have seen it with some of the elderly patients, that they have like soft movement of their face and they just cannot control it. Sometimes traumatic brain injury might induce orofacial dyskinesia. So this is orofacial or tardive dyskinesia. So both, they look clinically exactly the same. The difference is by the history, we know that the patient has been taking antipsychotics. The second type, which is oromandibular dystonia, and here there is, as you can see, there are contractions. This might affect any part of the face, the oral cavity, the lips, the tongue. The patient might protrude the tongue and put it back in the mouth, and the eyes as well. So the patient sort of close his eyes forcefully. So this is called oromandibular dystonia. Of course, dyskinesia and dystonia can affect any part of the body. The most common type of dystonia is that which affect the neck muscle, and it can affect any muscles, but we are here concerned about the problem in the head and neck area. So we are restricting our talk to oromandibular dystonia and orofacial dyskinesia or tardive dyskinesia. And regarding oromandibular dystonia, the main cause is genetic susceptibility. Actually, they did not find a reason for oromandibular dystonia. They thought it is a sort of psychological disorder, but it tended to now become clear that there is no underlying psychological problem in that person. He just developed this condition, and there is genetic underlying cause or genetic predisposition to develop this condition. This is all regarding the movement disorder. The last condition that I'll be talking about is auriculotemporal syndrome or Frey syndrome. This condition is caused by a cut of the nerves, the auriculotemporal nerve, and usually related to surgical treatment involving the face, involving the parotid area. And sometimes it might be related to damage of the nerve related to infection, chronic infection, or neoplastic pathology. And this is the, it affects here the auriculotemporal nerve, which is a branch of the mandibular nerve. It usually supplies the joint and supplies the auricle of the ear. And if the patient had trauma to the auriculotemporal nerve, the auriculotemporal syndrome results. So what happens here? There is abnormal neuronal regeneration resulting in parasympathetic cholinergic innervation of cutaneous tissues. So this image here shows what is wrong. So this is normal innervation structures. We have the sympathetic nerves that supplies the sweat glands and supplies the parotid. We have the parasympathetic that supplies the parotid. So as we are eating, the parasympathetic stimulation is needed, and the parotid will produce lots of saliva, while in sympathetic condition there is excessive sweating and there is decrease in the parotid stimulation. There is also, in addition to sympathetic and parasympathetic, we have the normal sensory branch and nerves that detect general sensation. So when there's a cut here, a trauma due to surgery, for example, or tumor growth, these nerves would get mixed up. So as you can see here now, the parasympathetic, it supplies both the parotid and it supplies the sweat glands. And what happens now when the patient eats, and this is a parasympathetic stimulation, at the same time it will stimulate the sweat glands and will induce sympathetic stimulation, leading to redness of the area. So this is, as you can see, the scar here, it is the site of the surgery. Probably it is the one causing the problem in the first place, and because of this scarring here, because of the damage that took place on the nerves in this area, there was a mix-up between sympathetic and parasympathetic. So as the patient starts eating, there is a swelling, there is redness, there is a sweating, which are signs of sympathetic activation that took place in addition to the parasympathetic stimulation needed for the saliva production. So this is a rare condition, but it is there, it is present, and any patient with a surgery in the parotid gland should be informed about the possibility of this or the risk of developing this condition. So this is all regarding this lecture. Hope you enjoyed it, and see you next time. Bye-bye.